Well, thank you very much. And once again, I am delighted and honored to be here. And I'd like to thank Patrick and the organizing committee for inviting me here today. I've given a variation of this talk in the past. I've also chaired some sessions where we talked about access to care around the world. And I'm pleased to say that I'm kind of more heartened by the kind of work that's going on around the world, demonstrating that access to care is improving for many patients with hepatitis C, although we do have a long way to go. And that'll be the focus of my talk today. Here are my disclosures. So we've heard this morning the remarkable treatments that we have for hepatitis C, of course. We learned from Patrick how just in a short, roughly 30-year time span, we are now with treatments that are universally effective for almost every patient that we can see with hepatitis C. Over 95% cure rates across all populations as we've already heard today. Nevertheless, so the main focus now isn't on drugs, new drug discovery, for example, but how do we get these drugs to the populations that need them and continue to treat those patients until we can achieve the goal, hopefully, of global elimination. Now, in the interferon era, we've talked about this cascade of care. You may recall we have patients who get diagnosed with hepatitis C, and then how many get referred to a specialist is smaller number than how many actually get treated, and then how many actually get cured. In the interferon era, those are very tiny numbers at the end of the day. And we're now starting to see some data from the era of direct-acting antiviral agents. And I wish I could say that it was fantastic, but it's not. And it still demonstrates that we have some ways to go. So this is some data out of a UK teaching hospital between 2013 and 2016, so right in the DAA era. It evaluated the linkage to care and outcome. They tested about 38,000 patients for hepatitis C, and they found about 1%, about 350 were diagnosed with hepatitis C. And when you look at the cascade of care shown on the bottom half of this slide, you'll see that at the end of the day, about only half of them were offered an appointment with a specialist to treat hepatitis C. About 40% of those diagnosed went to that appointment, and only about a quarter actually started treatment, and now only 20% actually got treated. So that cascade of care still has not, we'd like to see 100% of patients get diagnosed and 100% of them get offered treatment, and then ultimately 95% or more to get cured. So we still have a ways to go here, and there are many programs that are going on to try to improve these aspects, and I think as you'll see, we are making some progress. But it also illustrates that across many different levels, there are barriers to hepatitis C treatment. And these barriers can be societal levels, where the type of healthcare system can impact that, and that's what we see sometimes in the United States. Community levels, where patients are stigmatized by having hepatitis C. And interestingly, we'll see some data out of the inmate population where that can have an impact on their willingness to be treated. The cost of care, the location of clinics, and then the patients themselves have some inherent barriers where they may not choose to be treated for hepatitis C for a variety of reasons. And providers also contribute to some of those barriers. So we have to look at all these different levels and figure out what the solution is. Not every barrier is the same, not every level of barrier is the same, not every country has the same barriers, but there are certain common features across all of them. I don't know if you're familiar, but at least in the United States, dictionaries tend to the main dictionaries, the Oxford Dictionary in the UK and the Merriam-Webster Dictionary in the United States, picks a word of the year that kind of summarizes the important aspects of what's going on in that country. It might be related to the number of web searches, for example, of that word, or how often that people are trying to define this word. And in 2018, that word was justice. And justice is defined as the quality of being fair and reasonable. And nothing could be more important when we talk about treating hepatitis C than justice. And as you'll see, we are making some improvements, but for many years, it was a rather unjust process in our ability to treat hepatitis C. And this was actually exemplified also in the United States. So this is the state Medicaid programs. We have 50 states. Each of them is administered by an individual state Medicaid program that kind of makes their own rules. They all have some sort of foundation, but most of them make their own rules for specific aspects. And what you can see here, this is a grading system on access to hepatitis C care based on a number of factors. This was put out by the National Viral Hepatitis Roundtable. And the darker the state is in here, the worse the grade is. So you see here, grade of F. You don't want a grade of F, whether it's in your university studies or if you're a state with treating hepatitis C. So here's just an example. Well, F, well, the cake was great, the ice cream was delicious, but deep down inside, he knew that someday his parents would discover that F was not for fantastic, right? It was actually for failing hepatitis C treatment for many patients. And why is that? What is the problem? Well, there have often been arbitrary restrictions that have limited hepatitis C treatment across many states. And some of those restrictions were liver damage, right? Many states required at least F2 fibrosis in order to treat patients. So therefore, F0s, F1s would not be treated. Some states for many years required actual cirrhosis before being treated, okay? And similarly, they required people to be sober, off alcohol, off drugs, before they could be treated. As I'll talk about a little bit later, one of the main aspects now we're focusing on with hepatitis C therapy is actually the issue of harm reduction and treatment as prevention, so that even though people may still be actively engaging in drug use or actively using alcohol, if we can remove a harm to them, we still can improve their outcomes, not just for them, but as you'll see, also potentially for society. But nevertheless, in state Medicaid programs in the US, there are still a lot of these arbitrary restrictions. I will say that this is data from 2017, so not that long ago. Even in the last year, we've made progress. Numerous states have further dropped their fibrosis restrictions. Those who required cirrhosis are requiring less degrees of fibrosis to be treated, and those who started with F2 are now treating people with even milder degrees of fibrosis, like we are in the state of North Carolina. If we contrast this with Europe, as an example, we see that in general, European countries have fewer restrictions for fibrosis or substance use disorders compared to the United States cohorts. So here you see the lighter colors tend to be less restrictive. And overall, as countries, Europeans are much more advanced in their approach to treating hepatitis C with generally fewer restrictions. Each country has some of their own restrictions, but in general, overall, you can say that there are fewer restrictions than there used to be in the past. One thing that's common to many European countries, and had been to the United States as well, was that many European countries restrict hepatitis C therapy to specialists within their communities. And in reality, most countries really do not have enough specialists to treat all the hepatitis C that is out there in all the far reaches of their community, not just in their urban settings, but also in their rural populations, et cetera, where individuals may not have the same ability to access specialists. And this is common across European countries. It's also common around the US. And there are a number of novel approaches that we can take, that we should be taking, to try to get treatment out into the community where it's most desperately needed. One of these is telemedicine programs, for example. Telemedicine is, of course, where you have a single provider utilizing a web-based system, for example, or usually web-based system, that is managing a single patient. So the patient is actually in front of the provider, answering questions of that provider, that physician, or other healthcare provider, and the healthcare provider is actually dictating the care for that particular treatment. This has been utilized in many different settings. This is a recent example out of Spain that was presented at the AASLD liver meetings just in November, and demonstrated that it was very effective in terms of treating patients, and it was also very cost-effective as well, so that you could have a specialist in a remote location treating a patient who's an inmate somewhere else, and cure rates were excellent, as well as they demonstrated the costs were improved. So that's a one-on-one approach. A more novel approach that's been utilized, and I've mentioned this previously, is this Project ECHO, which of course is being expanded now around the world. And this was championed by Sanjeev Arora. The idea was to take primary care providers and to teach them how to treat hepatitis C. And you make a force multiplier where that one specialist now can train 10 providers, and those 10 providers can go out and treat 1,000 patients. So you see this force multiplying effect that's different than telemedicine. And many of us call this telementoring, because the specialist is mentoring that primary care provider in treating hepatitis C. Sanjeev demonstrated this in a difficult era when we were still using interferon treatments, that primary care providers could affect excellent sustained virological response rates in patients with hepatitis C with interferon-based treatments. Lots of side effects, many things to worry about. So you can imagine how much more effective it would be today in the DAA era, where we have many fewer things to worry about, many fewer comorbidities, many fewer adverse events for the patients that we're treating with hepatitis C. So this has been expanded a lot in the United States, and it's also being expanded to Europe. I'll be curious how many of you may have been participants in any of these kinds of programs. So in North Carolina, one of the things that we're seeing is the opiate epidemic is impacting North Carolina quite greatly. The coast of North Carolina, as well as the mountainous regions of North Carolina, have about a 250, 300% increase in new cases of hepatitis C infection. And very few of those patients can actually access specialty care, which is usually in the central part of the state of North Carolina. We're a fairly rural state overall. So we've implemented this new model working with the North Carolina Department of Health and Human Services, modeled after Project ECHO. So it's a collaborative project between University of North Carolina and Duke University. We have peer-to-peer teller-mentoring models. We've now trained roughly about 100 primary care physicians in the state of North Carolina who are very interested to treat. And what you see here is they've screened now probably 10,000 patients for hepatitis C. They've identified about another 750 new cases of hepatitis C that are previously unknown. And we're doing a little bit better. 3/4 of these patients so far have been prescribed medication, so that's better than some of those cascades you've seen previously. And when you look at the rate of cure for patients who have had the ability to get cured, meaning they have the sufficient follow-up, 12 weeks post-treatment, et cetera, you'll see that actually now more than 90% of patients are being cured by these primary care physicians. So the model works extremely well. It worked in the interferon era. It's working extremely well in the DAA era. And it's something that many of you may have participated in or should think about as you're trying to roll out elimination projects in your countries. This is another study demonstrating, again, primary care physicians, clinicians can certainly treat hepatitis C in the community. Very high rates of cure. Same thing, the cascade of care is improving, but still not 100% of those diagnosed for those who ultimately get cured. So we still have a ways to go. But by reaching out and trying to keep treatment within the community, as opposed to forcing people to go to see specialists, we will improve access to care across the board. Project ECHO is starting to be exported to Europe. This was a pilot study to evaluate the feasibility of ECHO in Ireland, as an example. Interestingly, private practice general practitioners were not able to participate in ECHO for a variety of time and financial constraints. So that's something to keep in mind. But state-employed health care providers did attend these web-based case conferences over several months and became quite facile in being able to treat hepatitis C. And they demonstrated increased expertise in the managing these patients, and then ultimately created their own local networks of practitioners to provide care to patients treating hepatitis C. And again, over time, by hearing new cases, by hearing your colleague express their opinions, et cetera, everyone learns from each other about the best way to manage patients, and again, eventually becomes their own local experts in the disease. So in 2018, justice, I think, was an important question. Trying to be more fair and more reasonable in treating patients for hepatitis C, improving access to care by local programs, removing arbitrary restrictions. And again, we have some ways to go, but we have made progress in that regard. I think I would like to suggest that for 2019, the word of the year, we hope, is going to be micro-elimination. And that's what we're starting to see on many different levels. And I know we have some luncheon sessions on this and some very specific country-specific aspects of microelimination. So I'm not going to touch on those. You'll hear about some of those during the lunch break. But microelimination is really important. And you can think of it as, if we think of what Lao Tzu said, a 1,000-mile journey begins with a single step. So if our goal is global elimination of hepatitis C, this may begin with multiple small micro-elimination projects. And a similar way to think about this is that when eating an elephant, take one bite at a time, okay? And eventually you'll get there. So the idea is that we have this, what seems like a daunting task of trying to eliminate hepatitis C globally. But if we can take small steps, if we take local projects or community projects or state projects or targeting certain populations, we can eventually get to a much larger, a much greater benefit to society. So as an example, some of these micro-elimination targets could be seen here, where they have a defined prevalence, a defined population that you can identify, sometimes a defined geographic area, as we've seen with some of these state programs. So for example, early on, you might think of when there are restrictions of treating only patients who had advanced fibrosis. Well, the most beneficent way to think of it was that was a micro-elimination project for people with advanced liver disease and not trying to restrict it to avoiding treatment for all the other patients, okay? But hemophilia patients, prisoners with hepatitis C, children, patients engaged in drug treatment units, people who inject drugs and networks, all of these, focusing on these particular populations can be considered as micro-elimination targets and certainly would be applicable across all countries. Persons who inject drugs, of course, not just drove the epidemic of hepatitis C in the past, but are now, at least in the US and also in parts of Europe, we're seeing this increase in new infections in younger individuals, so that soon we're going to have a bimodal distribution excuse me, of patients with hepatitis C. The baby boomer generation is older, being treated, or dying from their own comorbidities, and behind it we're seeing this new generation of injecting drug users, younger patients, 25, 30 years old and younger, who are now driving that new epidemic of hepatitis C. And when you look across the globe at the number of people estimated to be infected with hepatitis C who inject drugs, again, even though it's considered a micro-elimination project, it can be considered very daunting, and we have to do it individually within our communities. So even if you have the access to drugs, it's remarkable to think that that individual has their own personal barriers to being treated for hepatitis C. So even if you give everybody access to drugs, even if you give them access to specialty care, the question is, will they take advantage of it? So this was some data from Australia highlighting that the individual themselves provide certain barriers that must be thought about and potentially overcome in order to get them all treated. Many of them feel that their lack of symptoms, despite being infected for many years, makes hepatitis C less of an issue, and they're much less motivated to be treated for hepatitis C than they are to worry about their other social aspects of their life, including their continued injecting drug behavior. There are persistent negative impressions about the side effects of these medications. Every day in my clinic, patients still come to me having read old things on the internet or heard from friends from years past about these adverse events associated with these treatments, and hence they have not sought therapy earlier. Many believe that if they continue to use drugs, they'll be denied treatment, and that wasn't always an entirely incorrect assumption, but again, we've made some progress in recognizing that we do have to treat patients who continue to inject drugs, as treatment as prevention has been demonstrated to be effective. There may be competing adherence to their opiate substitution therapies, which on a daily basis is more important to them than worrying about treating their hepatitis C that's not going to cause liver disease for decades down the road, and they may not have adequate support. Many studies, though, have demonstrated that this is an ideal population to try to target and treat. Early on, a few years ago, we heard from the elbasvir-grazopavir data about patients who were in opiate substitution programs and being treated, but had excellent sustained response rates and relatively low rates of recurrence. And we'll talk about, I have a slide later about some of the later long-term follow-up of those patients. But we talked earlier about adherence for treatment, and it turns out that even persons who inject drugs can be fairly adherent to treatment, and even if they're not perfectly adherent, they still have very good likelihood of sustained virological response. And this was data that was presented at AASLD. You'll see that in the patients who completed 12 weeks, in this case of sofosbuvir or velpatasvir, they had very low rates of virological failure. If they finished on time or early, okay, they had 100% SVR rates. If they finish a little late, suggesting that they may have missed pills along the way, so their estimated time of finishing was earlier than what they actually did, you'll see the SVR decrease, but not horrendously so. So that you still can treat these patients who inject drugs and still affect a cure in many of this population. And one of the things that was restricting or making us more concerned about our ability to treat people who injected drugs was the concern about the high rate of reinfection. And in fact, when you look at the long-term follow-up, and this is the data I mentioned from the COSTAR study, the long-term follow-up suggests that the reinfection rate is still relatively low across many patients. Now, this is somewhat of a self-selected group who continued an opiate substitution therapy. We have to keep that in mind. But nevertheless, the rate isn't as high as any of us, I think, had originally anticipated. Here it's about 2 per 100 years of person's follow-up for reinfection of hepatitis C. Inmates, we think about that they're an ideal population to try to treat because they're in a confined space for a known duration of time where they have access to medical care. But when they've done structured interviews for those individuals, there were a number of barriers. One was the lack of HCV knowledge, stigma, confidentiality breach, leading to stigma. Other members of their inmate community would stigmatize them because they were known to have hepatitis infection. And then they still had inconsistent access to prison healthcare services. Even today, not all the best treatments are available across all the prison systems in the United States, and it's very variable. Some of this is being changed by lawsuits that are being brought against the prison systems by inmates throughout the United States, as an example. But there are also a number of positive reasons why inmates are excellent candidates for treatment. They do have access to health care. If they do opt-out screening rather than opt-in screening, you're more likely to identify patients who have hepatitis C. Prison life is still fairly stable, and they don't have any competing priorities. They're getting fed, they're working, they don't have to worry about it, and just taking their medications is much more likely to occur. They're much more likely to be adherent in these settings without having to worry about all the other social distractors. So in a lot of ways, inmates do make ideal candidates to be treated, and we have to focus on that group too, because once they get released, that's going to also impact what happens in our communities. Well, there are many examples of successful microelimination program, and I'll just go through a few. Well, the Veterans Administration in the United States, again, a large, but a fairly confined population. They made a focused effort over the last 3 or 4 years to offer treatment to all veterans. And as you can see here, they had proactive outreach, they had nurse navigators to help them get through the system. They utilized non-physician providers, and they were treating tens of thousands of patients in the VA system, to the point now where patients with previously diagnosed patients with hepatitis C are almost non-existent within the Veterans Administration system in the United States. So a remarkable progress in that regard. Countries in Europe are also having tremendous success in microelimination campaigns. The Netherlands, where a relatively low prevalence, so they have a favorable hepatitis C epidemiology, targeted some of these patients that I had mentioned as good microelimination targets. They had a multi-pronged approach that included addiction care, treating patients who are in detention, utilizing non-specialist providers, and other interventions over time, and did everything from awareness campaigns to testing and diagnosis to linkage to care, making sure they had access to the medications and qualified health treatment services, and ultimately monitoring them for success. And while this program just started in 2016, you'll see that in the HIV-infected population, it looks like they've eliminated 76% of hepatitis C co-infection, a tremendous achievement. And they're starting to target now the hemophilia population, where about a quarter of them who were infected with hepatitis C have now been cured of hepatitis C. So again, over time, we expect to see improvements in this. One of the really interesting models, again, you're going to hear some more during the lunch group about well-established elimination projects, but this is Iceland. Anybody here from Iceland? No, okay. I never visit Iceland. I hear it's a lovely place. They are doing a really remarkable job. It's a small country, 330,000 patients. They only have about 1,000 patients with hepatitis C, so it's like a great proof of concept on how microelimination can work. Just to put it into context, in North Carolina, we estimate about 140,000 people with hepatitis C just in the state of North Carolina where I practice. My group has probably treated and cured more than 1,000 patients over the last year. So just gives you an idea about the the magnitude of the problem sometimes. But nevertheless, they had a focused microelimination project. You'll see that their cure rates were 94 to 100% over time. And what was starting to be really interesting is that they're now seeing a reduction in the proportion of viremic patients at their hospitals when they're screening these patients. A 72% reduction here, 53% reduction here. And this is really important when we think about treatment as prevention. Treating people who are actively injecting drugs to prevent them from infecting other injecting drug users. These are individuals who between 2013 and 2017 had just started to use intravenous drugs. There was about a 13% prevalence of HCV viremia. After this elimination project, that same group, a group of people who had just started using drugs within the first year, the HCV viremia dropped to 0%, demonstrating that these targeted microelimination projects for the first time could be used to prevent infection in other people who are injecting drugs. Very important to keep in mind and something that we all will focus on. So, in summary then, our barriers to hepatitis C therapy still exist despite the availability of medications with near universal efficacy. These barriers exist at multiple levels, whether it's the patient, the provider, or the health system. And while every country has unique challenges, some barriers are common across all countries. The goal, of course, is global elimination of hepatitis C, but we have to take that one step with microelimination projects before we eat the entire elephant. And there are numerous examples of successful programs that indicate that you can remove some of these barriers and that you can improve access to care to effect better treatments for patients with hepatitis C. So thank you very much for your attention.